We shall now go on to our first speaker, Dr. Jay. On to you, Doctor, and he's going to be talking on CSC.
Thank you so much for the kind introduction. Because I believe ARC is doing such a great job, and when we are talking about advanced imaging, I decided that we will just jump on to the OCT angio. I have recorded a video because of some time constraints, so I'll just go ahead and play the video. And if there is any difficulties in listening or not clear, let me know. Everybody, I'll be talking about OCT angiography in CSCR. These are my financial disclosure, and none of them are relevant to this presentation. I'll show a couple of examples where OCT angio could be useful in cases in CSCR. Let's start with Courier Capillaries flow voids. As you can see in these pictures, the Courier Capillaries slab clearly shows areas of flow voids, which is a pretty common feature in CSCR eyes as well as in fellow eyes. However, if you take the segmentation deeper in the choroid, you will be able to see the deeper choroidal vessels as shown on this Courier Capillary slab on the top right, where you are able to appreciate the Pachy vessels, dilated choroidal vessels, and other features which we would like to see by using indocyanine green angiography. The next utility of OCT angio in CSCR is FAPED evaluation. We all have learned that there could be a flat irregular pigment epithelial detachment, which could be hyperreflective as shown on the top picture, and as hyporeflective as shown on the bottom vertical scan. This is the vertical and horizontal scan of the same eye, and I will show you this eye where we were able to see the different kind of CNV formation in the hyperreflective FIPED. However, the hyporeflective FIPED did not show any choroidal neovascular membrane. As you can see on these pictures on fluorescein angiography, and we are not able to appreciate any network on fluorescein angiography. However, indocyanine green angiography does show some form of network, but this network of hyperreflective FIPED was clearly noted on OCT angiography as shown with this yellow arrow. Let's look at how do we use OCT angiography for CNV detection. Many times patients with CSC present with exudate as shown in this example. If you do a OCT angiography, you will be able to appreciate a choroidal neovascular network as seen in this example very easily without doing any invasive test. Let's look at the fellow eyes of CSCR with CNV. This is one of our recent paper where we showed that OCT angiography can be used to look for CNV formation in the fellow eyes of CSCR. This is one example, and this is another example where you can see that the left eye clearly shows the presence of choroidal neovascular membranes on the OCT angiography picture. We also showed in the long-term follow-up of these fellow eyes with CSR CNV that approximately 33% of these eyes tend to develop CNV on OCT angiography. What about cystoid degeneration in CSCR? This is one of the very complex situation in patients with CSCR where we are able to see the cystoid degeneration. In these cases, we showed that approximately 45% of these patients had choroidal neovascular membrane on OCT angiography, and this could be the cause for persistent fluid in these eyes. This is another example of patient with CSCR with cystoid macular degeneration, where you can see that there is a presence of CNV network on OCT angiography. Let me show you one of the very interesting case where OCT angiography was very useful. I had a 56-year-old female who presented with both eyes vision loss for last 4 years. Her right eye visual acuity was 20/25 and left eye was 20/80. These were the OCT pictures back in 2013, where we did not have OCT angiography. Here we are able to see the presence of subretinal fluid, and I suspected some form of early network on ICG. And this patient
went ahead with low fluence PDT, and you can see that after low fluence PDT, the fluid resolved, and this patient showed foveal thinning, and this patient was on a regular follow-up, and she did really well, and the eyes remained dry throughout the five. At 5 years follow-up, she presented with a sudden vision loss in the left eye. Her vision dropped to 20/80. On color fundus photographs, you can see subretinal hemorrhage. On OCT, there is a reactivation of the CNV. However, if you look carefully on OCT angiography, you can see on the outer retinal slab, there is a type 1 network which is present at the deeper level, but there is a differential flow signal which is shown with the help of thick arrows, which we suspected to be a type 2 network, which is shown as a more hyperreflective signal on outer retinal slab. And this patient underwent 3 cells of injection, and she was put on Aptus. And here you can see that the fluid has completely resolved, and you can see that the type 1 network is still present. However, it is not active. If you compare with the pre-injection OCT angiography slabs, here you can see that the hyperreflective signal which was seen on outer retinal slab has completely resolved. However, the type 1 network which was present before is still persistent. This is how we use the OCT angiography in understanding the differential flow signal strength, which could actually explain the type 1 and type 2 CNV network. With this, I would conclude saying that OCT angio plays an important role in CSCR. I particularly use it for feedback evaluation or CNV detection in complex situations. However, at the same time, we should be very careful about artifacts. Therefore, the multimodal imaging is very useful. The common question asked is that can it replace ICG angiography in this disease? I would say we are still uncertain. There is lots to learn as we move forward. With this, I would like to acknowledge LV Prasad Eye Institute, where I practiced in India. Thank you very much for your attention.
Thank you very much, Doctor. That was an amazing talk, and I would want you to stay on for the discussion, which is going to be done by Dr. Muralidhar.
Thank you, Jay. That was a wonderful presentation of the use of OCTA. And especially as I agree with you that the chief use of OCTA in chronic CSR is to detect CNVMs, which sometimes even on FFA or ICG or elusive. One of the things that often baffles me is, when there is an atrophy and then there is a choroidal vessels showing through that. Sometimes there could be a confusion regarding CNVM versus the normal choroidal vessels, and sometimes we really find it hard to distinguish. What are your tips on this? And secondly, you also showed a patient in which post PDT the type 2 CNVM remained the same, right?
Sorry, the type 1 CNV.
Type 1 CNVM did not change at all. Did you give any anti-VEGF in that situation?
No, so that was one of the interesting cases, I would say, that really taught me a lot, that OCT angio can still show you the network which may not be active. So that was the network which we were seeing almost for 5 years. And then she came in the clinic with the sudden vision loss, with the subretinal hemorrhage, which itself is very uncommon if you really think about type 1. But when we looked at the OCT angio, there was a differential signal on the OCT angio where you could see that the type 1 network, which was there for last 5 years, on top of that, there was a more hyper reflective, or I should say a higher signal on OCT angio. And that's where we could correlate it with the type 2 component. So I thought that this could be really a great use of OCT angio, where you are able to actually differentiate the signal strength from above and below the RPE. So, and we saw that as soon as we started her on anti-VEGF, not on PDT, but on anti-VEGF, as we know that the type 2 regresses very quickly, and that's what we saw in that case as well, where the type 2 component regressed after the injection, but the type 1 remained same as it was earlier. Anand had a question.
Yeah, Jay, again, fantastic presentation. Always wonderful to listen to you about, especially on CSE. I just wanted to know, again, with that same case with respect to Zaltrap, given that experience, when you have a senior that you, post CSR that you feel has regressed or is stable, and you have this network lying quiescent there, do you actually follow up this regularly and look for those pruning small vessels like the way we, try to do in MNB, AMD, MNB cases? You actually, try to look back and see if there's an increase in those small little pruning vessels.
Yeah, absolutely right. And I think that is where we all have to understand that OCT angio, particularly in CSCR, the way Dr. Muralidhar was mentioning, that because the inner choroidal vessel, inner choroid is really thin because of the pachychoroid, everything is pushed upwards. So it is possible that you may be able to see the vessels much more clearly and without any activity. So I think OCT angio will show you the vessels, but the more important thing is that whether those vessels are active or not, and then we can use some other signs such as a subretinal fluid, or if the FIPID is increasing in size, or you just mentioned look for the pruning of the vessels as we follow up with AMD cases. So it's like a double-edged sword.
Yeah, I think George sir wanted to make a point. Yeah, quickly.
Yeah, thanks, Jay. Once again, bringing this up and OCT angio. Now, since even in chronic CSR, the pathophysiology have moved into inner choroidal Courier capillary ischemia, especially shown as, on OCT angio, overlying this huge pachy vessels which are compressive in nature. That's the first point that Jay mentioned. About the inner choroidal ischemia, that is low flow areas. Second thing, I do 100% agree with that for flat irregular PEDs, the problem with fluorescein angiography as well as ICG angiography to pick up this neovascularization, fluorescein will just show diffuse leakage because there will be diffuse RP epitheliopathy, and decompensated RP just shows up as late diffuse leakage. You cannot pick up these fine new vessels within the flat irregular PD. So I 100% agree because OCT angio has a high sensitivity in picking up this subtle neovascularization, as Jay had shown beautifully here. And otherwise it will be missed in those situations. And it's very important for the retinologist to segment at the correct plane, because as Dr. Muralidhar was mentioning, that artifacts come, especially if you're looking at the various automated slabs. If you do a careful segmentation, I think we can pick up quite well.
Oh, thanks a lot for the great discussion which followed, and all the best to you for your OR today, Dr. Jay.
Thank you so much. Thanks a lot.
Having you over in more